So good morning and afternoon, depending on where you are. Thank you all for attending today's Journal Club webinar. It's sponsored by the American Thoracic Society Allergy, Immunology, and Inflammation Assembly. My name is Amit Berry. I'm an instructor of medicine at Washington University School of Medicine in St. Louis, Missouri, and I'll be moderating today's webinar with Nicholas Hogan, who's an assistant professor in the Division of Pulmonary Critical Care, Sleep Medicine, and Physiology in the Department of Medicine at UC San Diego Health. Today, we are very excited to discuss the paper entitled Effect of Dupilumab on Exhaled Nitric Oxide, Mucus Plugs, and Functional Respiratory Imaging in Patients with Type 2 Asthma, VESTIGE, a randomized double-blind placebo-controlled phase 4 trial. It was published in the Lancet Respiratory Medicine. We are very fortunate to be joined today by the first author, Dr. Mario Castro, who is the L.E. Phillips and Lenora Carr Phillips Professor and Chief of Pulmonary Critical Care and Sleep Medicine, the Vice Chair for Clinical and Translational Research, the Director of the Frontiers Clinical and Translational Science Institute at the University of Kansas School of Medicine. His research is focused on the pathogenesis of asthma and treatment of asthma, especially in severe disease. He is the author of over 30 chapters and books and over 300 peer-reviewed articles. Over the past 25 plus years, Dr. Castro has trained over 40 junior clinical and translational scholars, including me at one time. He's widely recognized as an expert clinician, an excellent mentor, and a skilled educator with significant commitment to the development of young investigators' careers. We are also fortunate to have two expert discussants joining us today. First, Dr. Trishul Siddharthan, who's an associate professor of medicine and the director of clinical research in the Division of Pulmonary Critical Care and Sleep Medicine at the Miller School of Medicine at the University of Miami. His research focuses on global burden of COPD and disease management, as well as functional assessments of ventilation and perfusion in COPD. He has over 100 publications in high-impact journals and has contributed to book chapters, including the U.S. Surgeon General's report on smoking cessation. He has been awarded funding from the National Institutes of Health, the Chest Foundation, and the Department of Defense to support his research activities over the past decade. Next, Dr. Jessica Sieren, who is the Deputy Director of the Advanced Pulmonary Physiomic Imaging Laboratory, Associate Director of Career Enhancement for the Holden Comprehensive Cancer Center, and an Associate Professor of Radiology and Biomedical Engineering in the Division of Cardiovascular and Thoracic Imaging in the Department of Radiology at the Carver College of Medicine at the University of Iowa. Her research focuses include optimization and standardization of CT imaging for robust quantitative feature extraction, characterization of biological and technical sources of variability affecting quantitative lung metrics, and the development of radiomic and machine learning models for cancer classification, risk stratification, and outcome prediction. If you have any questions for the presenter or the discussants at any time during the webinar, you can enter them in the Q&A section at the bottom of our Zoom call here. We will hold discussion questions until the end. And now I will turn it over to Dr. Castro.
Thank you, Amit. And Amit, should we encourage him to post questions in the chat, or do you want to do it afterwards?
No, they can post questions. I think the audience folks have access to a Q&A button. It's on the bottom of your Zoom. It may be under the ... more. If you guys want to post questions there, we will take them at the end, but they can post questions throughout the webinar.
All right. Thank you for clarification. And I do encourage people to post questions as we go. And thank you for the kind introduction, and thank you for our other panelists for joining us. Excited to present this data from VESTIGE, and I think it's certainly has allowed us to kind of think about how we use imaging in a much more quantitative fashion to really advance the science, and also think about different subsets of patients and how they could be targeted from a therapeutic strategy. So I just want to give you a little background all about mucus plug, because just not even a decade ago, we weren't talking about mucus plugs other than the post-mortem pictures that occasionally we would see. And this emanated from some work that Eleanor Dunnican did when she was at UCSF in the Severe Asthma Research Program. Eleanor now is in Ireland. And first, we had to establish, how do we quantify mucus plugs? And so, as demonstrated here in this diagram, we first looking at these mucus plugs in an airway. And as you can imagine, this technically is not the easiest thing to do, to scroll through a CT and count every segment, but that's exactly what we did. We did a training set first with 5 different chest radiologists from around the country, and looked at their degree of agreement. Well, not too surprisingly, there weren't the greatest agreement in some individuals, and so they had to go through some retraining actually in terms of consistency of what they were calling a mucus plug. But as demonstrated here in the middle, it had to be a mucus plug that's completely occupying the entire lumen of the airway to be called a mucus plug. So if it was just partially occlusive, it was not called. And so each time they would have to go to each one of these colored bronchopulmonary segments. And if you had any positive mucus plug, it would count as a score of 1. And since we have 10 segments on the right, 10 segments on the left, Amit could probably tell you I had to teach him a little bronchoscopy back when he was a young child. But each one of these segments, we had to kind of go through each of those segments and count whether or not there was plug. And therefore, you could have a score basically from 0 to 20. And what we found was that over half of the subjects had 1 or more mucus plugs, which we now define as a mucus plug phenotype. And we can talk more about at the end. We don't see this very often in healthy controls, and in SARP, this was only 1 of the subjects that had a mucus plug. So we then built upon that work from Eleanor with this work from Monica Tane, who's also at UCSF. And Monica built on that work by looking at what happens to these plugs over time. And as you can see in this patient here at baseline, and you can follow those mucus plugs over time, you can see that some persist, some resolve over time. And so when you look at the averages, really that doesn't demonstrate that resolution of mucus plugs, but you can see on average maintaining about a score of 3. Keep in mind, about half patients don't have a mucus plug, but some of those patients that are absent at baseline actually do develop mucus plugs over time. In some subsequent work by Brendan Wan, he then even went to this kind of more in-depth analysis of the mucus plug and described them volumetrically on the CT scan as either being short and stubby or long and stringy, greater than 12 millimeters. And you can see that we studied the evolution of these mucus plugs over time. And what we learned is that this is a dynamic process. If you were thinking about a mucus plug and that was post-mortem, you would say, oh, that's a cast. It doesn't ever change in the patient once they develop it. Well, that thinking is wrong. What we've learned is that plugs are actually dynamic, in that you have these long, stringy ones, which go over, can go over multiple segments, that actually completely resolve over time. And this is, again, without any therapeutic intent. These patients were in the SARP program, which is a natural prospective observational study, not intervening in these patients. So we learned a lot about these plugs and their distribution and their persistence over time. And so this phenotype now has really changed our approach to thinking about how this relates to our patients' underlying morbidity. And what we've learned is that if you have significant mucus plug burden, and by that we mean having 4 or more segments or greater than 3 mucus plugs, that is considered this high mucus score. In these patients, you can see have significant reduction in lung function. This is both true pre and post bronchodilator. All these CTs were captured post bronchodilator. And this average FEV1 is in the mid 50s. So this is asthma. I mean, this is severe asthma, of course, but these patients have significant airflow obstruction due to this mucus plug burden. We also looked at air trapping, and you can see again that there's this increase in air trapping with this higher mucus plug burden. As we'll talk about as we've learned more about how these mucus plugs fill an airway and distal to that plug, there's this air trapping that occurs. It makes a lot of sense why we would say that this is now a therapeutic biomarker that we can tackle to try to reverse that underlying pathophysiology in patients.